Welcome back to the Deep Dive. Today, we are undertaking a pretty essential mission. We are cracking open the dense, clinically critical chapter on sexually transmitted infections from Davidson's medicine.
And this really isn't about just reading the textbook aloud. Our audience today, particularly our first and second year medical students, you need knowledge you can actually deploy.
Right.
So our mission is to rapidly extract, synthesize, and I suppose anchor the critical, clinical, diagnostic, and epidemiological concepts of STIs. We want to turn a challenging stack of sources into memorable, clinically relevant patterns.
Exactly. Think of this as your high-yield study guide. We're focusing on the patterns that stick, the statistics that really matter, and the clinical distinctions that save you time in the exam hall or in the clinic.
You have to go beyond just memorizing the bugs.
Totally.
So let's start with context, the consequences.
Right.
STIs are generally defined as infections transmitted via moist mucous membranes, so the genital, anal, and oral sites.
And while you might think of them as just acute sort of localized annoyances, the real danger is, in the long term, systemic consequences of untreated disease, isn't it?
It is. The consequences are devastating globally. We're talking chronic pelvic pain, which can be, absolutely debilitating.
And infertility from tubal damage.
Yes, and a shocking link to genital cancers, including cervical and anal carcinoma. I mean, these are silent epidemics leading to massive morbidity.
Wow.
And here is a critical insight you absolutely must anchor early. Ulcerative STIs, especially those caused by herpes simplex virus type 2 or HSV2, they significantly increase the risk of acquiring HIV. The source material states that the presence of these ulcerative lesions increases HIV risk threefold.
Threefold. That's a huge number.
It is. They aren't just local infections. They actively compromise the body's natural barriers and, they accelerate the risk for the most serious global viral threat.
So this sets up what seems like the central paradox of STI control. Syndromic management. So, treating a patient based purely on their presenting symptoms, like a discharge or a sore,
Right.
is a global lifesaver. It's essential in places where labs are scarce or, results are delayed.
Yes, but here's the paradox. The majority of the most dangerous, complication-causing infections are completely silent.
How silent are we talking?
We're talking 50% of people with gonorrhea or syphilis, and up to 80% of individuals with chlamydial infection are completely asymptomatic.
That's staggering.
It is. And it means clinical practice cannot simply wait for symptoms. We have to proactively screen populations, pushing beyond that syndromic management wherever we possibly can.
Okay, so let's unpack that. Before we even get into the bugs, into treponema or Neisseria, we have to talk about that first patient encounter.
The sexual history and the physical exam.
Exactly. And for a student, this is often the moment where, clinical skills meet this crucial sensitivity and where self-consciousness can really get in the way of a good consultation.
That anxiety is so real, and the source actually addresses it directly by establishing these non-negotiable foundations for trust and safety in the examination room.
Which are?
You must always start with the critical importance of informed consent. You have to clearly explain why a genital examination is necessary and exactly what it involves.
And the chaperone.
And crucially, the routine presence of a chaperone. This is just standard clinical care. It protects everyone involved.
I think a lot of students feel overwhelmed by the sheer anatomical territory they need to cover. They just focus on the complaint itself.
They do, but the source gives us a brilliant, structured approach, what we'll call the 10-point checklist. It guides the physical examination systematically, so nothing systemic or subtle gets missed.
Checklist is always good.
It turns a stressful encounter into a systematic process. So we start gently with step 1, the abdomen.
Why the abdomen first?
It acts as your non-threatening prelude. It's a way to establish rapport while you palpate for masses or tenderness, like, say, an enlarged spleen in specific infections, or tenderness that might suggest PID.
Right, so you're easing into it.
Exactly. From there, we transition into the core sites. Step 2 is observing the urethral meatus, which is key for sampling discharge, especially in symptomatic men.
And step 3?
Step 3 is the skin of the penis, and the source is very clear. If there's a foreskin, it must be retracted fully. You're looking for warts, ulcers, or any inflammation.
This brings up a really practical point, actually. How do you distinguish pathology from just normal anatomy?
That is a high-yield clinical nugget for any new student. You have to learn to distinguish pathology from normal. So features like coronal papillae, These are small, flesh-colored bumps around the corona of the glands, or prominent sebaceous glands. They are entirely normal. Recognizing these prevents a lot of unnecessary panic and, frankly, mistaken diagnoses in young patients.
That's a great tip. So what's next on the checklist?
Moving on to step 4, we inspect the scrotal contents. You're palpating the epididymis and testes to check for masses or tenderness that would indicate epididymoorchitis.
Which is a common complication of gonorrhea or chlamydia.
Exactly, especially in men under 35.
Okay, and for female patients?
In female patients, we inspect the labia majora and minora, that's step 5, looking for ulcers or vulvitis. Then step 6 involves the internal examination.
So using a speculum?
Yes, the vagina and cervix, using a speculum to visualize any discharge and lesions, followed by a bimanual examination to assess for signs of pelvic inflammatory disease, or PID.
And you're looking for things like uterine or adnexal tenderness there.
Precisely.
So the local tour finishes with steps 7, 8, and 9.
It does. Step 7 is the perineum and perianal skin, again looking for warts or ulcers. Step 8 is the rectum. The source specifically mentions proctoscopy, which is a procedure to visualize the rectum as necessary when you suspect proctitis.
And that's particularly in men who have sex with men, or MSM.
Correct. And step 9 covers the inguinal glands, assessing for significant lymphadenopathy, which is a classic feature of many STIs, including primary herpes or syphilis.
And then the final, really critical 10th point.
Yes, the critical 10th point. Extragenital sites. You have to check the mouth for pharyngeal infection or oral chancres, the eyes for conjunctivitis or signs of disseminated infection.
The joints for arthritis.
Right, particularly disseminated gonoccal infection, and the skin. The classic pattern you must look for is the non-irritable coppery rash of secondary syphilis, which uniquely involves the palms and soles.
So you're always looking for signs of scabies or manifestations of advanced HIV as well. It's a full body check.
It has to be.
Okay, so that comprehensive physical exam is only useful if the history guides it. But this is where many clinicians, even experienced ones, can feel some hesitation. So it raises an important question.
How do you do it?
Yeah, how do we navigate these really sensitive questions about sex life and practices without sounding accusatory or causing the patient to just shut down?
The key is preparation and language. The source gives us this brilliant anchor, which we'll call the gentle guide. It's 7 tactical tips designed to normalize the conversation and make the patient feel safe, sharing what can be very vulnerable details.
Okay, let's walk through them. Tip 1.
Tip 1, start with a simple framing statement. Something low-key like, to complete your care, I need to ask a few questions about your sex life. Or, thinking about your sex life, I have a few specific questions.
So it sets a professional tone, defines the boundary.
Exactly. Then tip 2 mandates open, inclusive language. You never assume a patient's orientation or their relationship structure.
So using the neutral term partner rather than boyfriend or girlfriend.
Yes. And tip 3 insists on avoiding euphemisms. We use medical terminology for precision, so you use vagina or penis, not vague terms like down below.
A crucial point for risk assessment is tip 4, which is to focus on events, not labels. So you don't ask, are you sexually active?
No. You ask, when did you last have sex? Any sort of sex. This grounds the risk in a specific time frame, which allows you to establish the window for potential infection.
That makes sense. What's tip 5?
Tip 5 is about permission giving, which is a subtle form of normalization. So instead of asking a binary question, you offer a spectrum. Have your partners been men, women, or both?
It validates all possible answers right from the start.
It does.
Now, tip 6 is an advanced technique which I find fascinating. It's inviting the non-acceptable answer.
Yes. If you just ask, did you use a condom? The patient might feel compelled to say yes, even if they didn't. There's a social pressure there.
Right.
So to mitigate this sense of judgment, you can phrase it negatively. So was that without a condom? Or did you use condoms every time? Or were there a few times where you didn't?
It's like a bit of conversational judo. It reduces the moral weight of admitting risk behavior, so you get more accurate data.
Precisely. And finally, tip 7, actively mitigate your own personal values. As clinicians, we have to avoid assumptions like presuming serial monogamy.
So if you ask, when was your last previous partner? You might miss concurrency.
Which is a significant behavioral risk factor. The goal is clinical relevance, not sociological analysis.
This focus on non-judgmental language leads us right into the necessity of inclusive care, especially around sexual orientation and gender identity, which are protected characteristics in modern healthcare.
They are, and the core practical takeaway here is that You have to move beyond binary gender when you're ordering tests.
So it's all about anatomy.
Absolutely. Clinicians must shift their mindset to providing tests and investigations based purely on anatomical sites at risk. For instance, a trans man may still have a cervix and therefore require cervical screening and testing if reporting vaginal exposure.
Or a trans woman who has sex with men via the rectum needs rectal swabs.
Exactly. Care is dictated by anatomy and exposure, not by gender markers on a chart.
Okay, so if we've mastered the history in the exam, how do we compile all that data to decide who actually needs screening? The source summarizes the risk factors really well, which we can visualize as the syndemic stack metaphor.
I like that, the syndemic stack.
Yeah, where layers of risk just compound each other.
The stack starts with demographic layers. These include younger age, specifically under 25, who are often prioritized for screening.
Men who have sex with men, or MSM, who represent a high prevalence population.
And anyone with a documented prior STI diagnosis, because previous infection is the strongest predictor of future infection.
Then you layer on the behavioral factors, so frequent partner change or concurrent partners, which just mathematically increases your exposure risk.
Right. Then there's non-use or errors with condoms, and the use of recreational drugs during sex, often termed chemsex, which impairs judgment and increases risk-taking.
We even have to consider modern technology, don't we? The use of dating apps, which just increases the speed and volume of sexual mixing.
It does. So when a patient sits across from you and reports multiple layers in this stack, say they're young, they have a prior STI, concurrent partners, and they're using apps, their empirical risk is dramatically elevated.
Which justifies proactive screening regardless of symptoms.
Exactly. And one final practical note. STIs should never be excluded based on older age alone. High-risk behavior persists across the entire lifespan.
Time for a knowledge check. So you've completed the history and are moving to the physical exam. If a male patient presents with an uncomplicated penile ulcer, can you name 2 specific non-genital anatomical sites you would inspect and why?
Okay, think back to the 10-point checklist. You absolutely must check the mouth, for secondary syphilis manifestations or oral herpes, and the skin, paying special attention to the palms and soles for that characteristic rash of secondary syphilis.
And the lymph nodes.
And you would also check the inguinal lymph nodes, which are vital for staging the ulcer.
So if you struggle to name 2, rewind and review that 10-point checklist. The key takeaway here is that an ulcer is a local manifestation of a potentially systemic disease.
And remember the foundation. The quality of your history dictates which anatomical sites need sampling. If the patient reports anal receptive sex, your history demands a rectal swab, even if the primary complaint is oral.
Right. Okay, here's where it gets really interesting for me. Once we've identified that high-risk patient, who is often asymptomatic, how does the public health system even find these silent infections?
The focus has to shift from responding to individual symptoms to large-scale population screening.
How do you do that?
The strategy hinges on moving testing accessibility out of the confines of the specialist clinic. Specialist clinics and primary care remain vital, but modern screening relies on technological advancements to reach that asymptomatic hidden population.
So you mean things like point-of-care testing or POCT for rapid results?
That's part of it, yes. But the real revolution comes from remote testing. We have home-based self-testing, where the entire diagnostic procedure is carried out by the patient and, more commonly, self-sampling.
And self-sampling is where the patient collects the sample, like a urine or vaginal swab, and then posts it back to a lab for analysis.
Exactly. Self-sampling for chlamydia and gonorrhea is now a dominant strategy in places like the UK because it just lowers all those barriers related to time, geography, and, embarrassment.
Is it as good as a clinician taking the sample?
Well, crucially, the technology, specifically NAT, is so sensitive that these self-collected samples are often as good as, or sometimes even superior to, clinician-collected samples, particularly for vaginal swabs.
So this remote capability allows for massive efficiency gains.
Huge gains. Testing kits can be ordered online, distributed through vending machines, or provided in outreach settings that meet high-risk populations where they are like youth centers or harm reduction services. It's all about population penetration.
So when we talk diagnostics, our core anchor is indisputable. NAT is king.
Absolutely. The nucleic acid amplification test is the gold standard for gonorrhea and chlamydia. Its sensitivity, its ability to detect even tiny amounts of bacterial DNA, is why we can rely on non-invasive samples like urine or self-swabs.
Okay, let's refine the sampling technique based on anatomy and practice. So for the male urethra, what is the best sample?
The preferred specimen for male urethral infection is still first void urine, or FVU.
The first part of the stream.
Yes, the first 10-20 milliliters of the urine stream. It contains the sloughed epithelial cells from the urethra, which concentrates the organisms. It's effective and non-invasive.
And for vaginal infection?
A self-taken vaginal swab is preferred. The patient can easily reach the required depth, and studies have shown it has excellent yield for chlamydia and gonorrhea.
But we have to remember the anatomical site testing.
Critically, pharyngeal and rectal swabs are not routine in the general population, but they are universally indicated by sexual history, and they are often universally offered to men who have sex with men, MSM, because of the high prevalence of asymptomatic infection at these sites.
But not all infections are detected by NAT. We still rely heavily on non-NAT testing. For instance, why is culture still essential for gonorrhea, even when NAT gives us rapid, sensitive results?
This is such a vital public health distinction. NAT tells us if the organism is present. Culture tells us how to kill it.
Ah,
Culture for gonorrhea, typically using selective media like modified New York City or MNYC, remains essential because it allows us to perform antimicrobial sensitivity testing.
and given that gonorrhea is, as you called it, the antibiotic Houdini.
Exactly. It's
Yeah.
constantly evolving resistance, so we need these sensitivity results to guide treatment if our first-line regimen fails, which protects us against the catastrophe of untreatable infection.
And blood test serology are fundamental too.
Yes, serological tests are critical for systemic diseases. We use treponemal EIAs or enzyme immunoassays for syphilis, IgG, and IgM, and of course HIV testing is always offered as routine with informed consent during any STI screen.
And hepatitis.
Hepatitis B and C and A, depending on risk factors like oro-anal contact, are also screened for in high-risk groups. It just reflects the epidemiological links between these pathogens.
And finally, let's not forget the rapid clinic tests, the old school stuff.
Direct microscopy is the quick win, especially in symptomatic cases. We use gram stain on urethral discharge to look for the classic gram-negative intracellular diplocarchae, the GNDC of gonorrhea.
And for vaginal discharge.
We use wet mounts to detect motile flagellate protozoa, so Trichomonas vaginalis, or the clue cells of bacterial vaginosis. It provides immediate presumptive diagnoses to kickstart treatment while you wait for the other results.
Stepping back, the sheer scale of the global STI burden is, well, it's staggering. The source reports over 376 million new cases of the 4 major curable STIs.
Syphilis, gonorrhea, chlamydia, and trichomoniasis.
Worldwide in a single year, 2016.
And that number doesn't even include the viruses. We have to recognize that the complications of this immense burden disproportionately affect women through PID, infertility, and ectopic pregnancy risk.
What are the drivers?
They're multifaceted. High partner change rates, sexual concurrency, increased mobility through travel, early sexual debut, they all play a role. But the most alarming microbiological driver is antimicrobial resistance, AMR.
Particularly in gonorrhea and Mycoplasma genitalium.
Yes. So to combat this, public health uses the 3 layers of prevention, which is from box 15.5 in the source. It forms a cohesive defense strategy.
Okay, layer 1.
The first layer is primary prevention, preventing the acquisition of infection in the first place. This is where large-scale efforts live. Comprehensive sex education, policy and legislation promoting sexual health, and crucial biomedical interventions like the HPV and HBV vaccinations, and pre-exposure prophylaxis, or PEP, against HIV.
So stopping it before it starts. The second layer is secondary prevention.
That's early detection to reduce spread and transmission. This includes targeted screening programs like the National Chlamydia Screening Program for young people, or routine antenatal screening for HIV and syphilis. The goal here is interruption, finding the asymptomatic carriers.
And the final layer, tertiary prevention.
That's treating the individual effectively to prevent onward transmission and long-term harm to their health. This includes effective treatment regimens, ensuring adherence, and the essential strategy of partner notification.
Partner notification or contact tracing.
It's the cornerstone of secondary and tertiary prevention working together. It involves identifying and contacting all exposed sexual partners for testing and sometimes for epidemiological treatment.
And that's the controversial but necessary practice of treating a contact without a confirmed diagnosis.
It is.
That sounds ethically tricky. Why would you treat someone without a positive result?
Because the benefit, especially for rapidly transmissible diseases like gonorrhea or syphilis, is the immediate cessation of the transmission chain. But you're right, it has to be carefully weighed against the risk.
The risk being?
Treating uninfected individuals with broad-spectrum antibiotics contributes directly to the rise of antimicrobial resistance, which is why guidelines are constantly updated to reflect local prevalence and resistance patterns.
All right, quick check. If a young person presents for routine sexual health screening and reports receptive anal sex, but is completely asymptomatic, what is the standard method for testing that specific anatomical site for chlamydia and gonorrhea, and what type of test is preferred?
You would use an anal swab, and the test is the nucleic acid amplification test, or NAT/OR. Remember, we test based on risk exposure, not just on symptoms.
Excellent. And if a clinician in a high-risk area gets a NAT positive for gonorrhea, why might they still need to perform a culture, even if it delays treatment?
Because the culture is absolutely critical for one purpose, to assess antimicrobial sensitivities. Given gonorrhea's extreme resistance capability, the culture allows the lab to determine which specific antibiotics will still work if the primary treatment fails.
Got it. Okay, so now we are in the clinic. Let's look at the classic clinical syndromes. Even with NAT readily available, the ability to recognize these syndromes is vital for immediate management and, for your differential diagnosis.
It really is. Let's start with urethral discharge in men. It's a visible red flag, but the nature of the discharge can already suggest the etiology. It helps you distinguish between gonococcal and non-gonococcal urethritis.
So first, gonococcal urethritis, or GU.
The incubation period is short, typically around 7 days, so fast. The discharge is classically described as profuse and purulent, thick, yellow-green, and often quite copious.
And you contrast that sharply with non-gonococcal urethritis, NGU.
Exactly. This group includes several causes: C. trachomatis, so chlamydia, M. genitalium, T. vaginalis, and HSV. The incubation is longer, 1 to 4 weeks, and the symptoms are often far milder.
So maybe just a thin mucoid or watery discharge, or just mild dysuria.
Right. Diagnosis, especially quickly, relies on the Gram stain smear. You're looking for PMNLs or polymorphonuclear leukocytes. Urethritis is clinically defined as having 5 or more PMNLs per high-power field.
And if you see the PMNLs A and D, the characteristic gram-negative intracellular diplococci, the GNDC.
That is a presumptive diagnosis of gonorrhea. If you see the PMNLs but no GNDC, you categorize it as NGU, and your empirical treatment has to cover the likely causes.
Which brings us back to our anchor: treatment in a pinch. In many clinics globally, results take days, so you can't wait.
You can't. Syndromic management means you immediately prescribe multiple antimicrobials to empirically cover the most likely suspects: chlamydia, often M. genitalium, and gonorrhea, balancing that immediate patient benefit against the AMR risk.
Now, for vaginal discharge, you have the pH detective anchor.
Yes, because when a patient presents with vaginal discharge, the first clinical hurdle is remembering that the majority of cases are not STIs. They're often due to local commensal disruptions.
So you use symptoms combined with simple pH testing to narrow the differential.
That's the key. So let's start with bacterial vaginosis, or BV.
Okay.
BV is a dysbiosis, not an inflammation. It causes increased discharge that's often homogeneous, thin, and off-white with a characteristic fishy odor.
Which often worsens after intercourse or during menses.
Right. And crucially, there is no itch or irritation. The vaginal pH is distinctly high, so above 4.5. And microscopy reveals the diagnostic clue cells of vaginal epithelial cells just coated in bacteria, which blurs the cell borders.
Okay, next, the classic yeast infection, candidiasis.
This is really the opposite of BV. It presents with thick, white, curdy discharge, often described as cottage cheese-like. Symptoms are intense vulval itching, burning, and external dysuria.
And the pH is low, so below 4.5.
Exactly. Microscopy confirms with the presence of fungal spores and pseudohyphae.
And now the STI cause that changes the game, trichomoniasis.
Trichomoniasis is caused by a flagellate protozoan. It causes a very distinct clinical picture: profuse yellow-green, frothy discharge, often accompanied by severe vulvovaginal inflammation, and a very high pH.
And the definitive, rapid clinical diagnosis
is finding the motile flagellate protozoa on a wet mount slide, though NAT is replacing this older method.
And finally, we have to consider the upper genital tract. If the discharge is purulent or mucopurulent, with blood staining or postcoital bleeding,
then you have to suspect cervicitis, which is often the primary presentation of chlamydia or gonorrhea in women.
Right. Now, for genital ulceration, you use the pain versus painless anchor.
This is a vital distinction we teach students. It helps differentiate the two major causes in the developed world: herpes simplex and primary syphilis.
And herpes simplex virus, HSV, is the painful diagnosis.
Yes. It presents as multiple, intensely painful ulcers. A key feature is that the lesions are often found at different stages simultaneously. So some are still vesicles or blisters, some are fresh, shallow ulcers, and others are scabbing over and resolving.
The primary HSV episode is systemically invasive too.
It is. Patients frequently report constitutional symptoms like fever, malaise, and often have severely tender bilateral inguinal lymphadenopathy. Complications can even include aseptic meningitis or urinary retention due to nerve involvement.
Now you contrast that with primary syphilis or the chancre.
The classic teaching dictates a single, painless, and highly indurated lesion. The induration, the hardness of the base, is the diagnostic hallmark. It feels firm, like cartilage.
But I've heard there are exceptions.
Well, while multiple syphilis lesions are common, usually fewer than 5, the induration typically persists. But here's the crucial clinical caveat, the exception that breaks the anchor. Anal chancres, particularly common in MSM, are frequently painful.
So the presence of pain does not rule out syphilis.
Absolutely not. You have to remember that. Diagnosis for all ulcers requires NATE for HSV and T. pallidum plus syphilis serology.
Okay, let's quickly address some other presentations, starting with genital lumps.
The vast majority of genital lumps are caused by anogenital warts, so HPV 6 and 11. They're usually exophytic, papular, or flat, often appearing in areas subject to friction.
And you have to differentiate them from molluscum contagiosum.
Yes, which are flesh-colored, umbilicated papules, and crucially, from normal structures. Teaching patients that coronal papillae or sebaceous glands are not warts saves countless unnecessary worries.
Now, proctitis inflammation of the rectal lining is clinically important because it is almost exclusively seen in MSM presenting for STI care.
It is, and the main culprits include gonorrhea, herpes, syphilis, and especially lymphogranuloma venereum, LGV.
Which is caused by specific invasive subtypes of chlamydia.
Right, the L1 to L3 subtypes. It's a key diagnosis in the UK in this population. The symptoms are distinct. Mucopurulent, anal discharge, rectal bleeding, pain, and tenesmus, which is a frequent, urgent need to defecate.
Finally, the critical emergency. Lower abdominal pain in women of reproductive age.
This mandates consideration of pelvic inflammatory disease, or PID.
And PID is an ascending infection.
Typically caused by chlamydia, gonorrhea, or M. genitalium. And due to the potential for catastrophic long-term consequences like infertility or ectopic pregnancy, diagnosis is primarily clinical. We have a very low threshold for empirical treatment.
What are the key signs to look for?
Signs include bilateral lower abdominal tenderness, often with rebound or guarding, adnexal tenderness on a bimanual exam, and the hallmark sign, cervical motion tenderness.
Sometimes called the chandelier sign.
Because the patient jumps off the table, yes. Immediate, aggressive, broad-spectrum antibiotics are crucial. The regimen is designed to cover all the major organisms.
So ceftriaxone for gonorrhea, doxycycline for chlamydia and MGen, and metronidazole for anaerobes.
Exactly. Delaying this multi-drug treatment dramatically raises the risk of life-altering sequelae.
Okay, let's focus our deep dive now on the pathogens themselves, starting with syphilis, the original great pretender. It's a disease defined by its ability to mimic other illnesses, to hide in plain sight.
And it's back! Rates are rising globally, with 75% of cases in places like the UK occurring in MSM.
So the key to understanding syphilis is understanding the great pretender's timeline.
It is. The organism, Treponema pallidum, is a spirochete that causes systemic disease even when symptoms spontaneously resolve. And that spontaneous resolution is the mechanism by which it progresses to latent disease and these late complications.
Let's start at early syphilis, the infectious phase. So primary syphilis.
This develops 9 to 90 days after exposure, commonly around 3 weeks. This is the stage of the chancre, the painless, indurated ulcer associated with moderately enlarged but typically non-tender inguinal lymph nodes.
The induration is the key. It feels like pressing on cartilage beneath the skin.
It does. And if it's untreated, the chancre heals completely within 2 to 6 weeks. It's often missed, especially if it's hidden in the rectum or the mouth. In MSM, extragenital chancres on the finger, lip, or anus are very frequent presentations.
Then, 6 to 8 weeks after the chancre first appears, the disease moves into secondary syphilis. This is the height of systemic involvement.
Yes, this is a classic multi-system presentation. Patients may have constitutional symptoms, fever, sore throat, generalized malaise, headache.
And the defining feature is the rash.
The rash occurs in about 75% of patients. It's typically macular or papular, non-irritable, and appears on the trunk and limbs. And crucially, it often involves the palms and soles. A highly diagnostic but rare finding that helps distinguish it from most other common rashes.
And I understand this is the stage where the pretender aspect is most pronounced.
Absolutely. The rash can be confused with acute HIV seroconversion, pityriasis rosea, drug reactions, or psoriasis. Furthermore, in warm, moist areas like the perianal region or the vulva, the rash can coalesce into these pale, warty, highly infectious lesions called condylomata lata.
And neurosyphilis can present here too.
The secondary stage is also the period where neurosyphilis often presents today, particularly as meningovascular syphilis, which affects the blood vessels in the brain.
If it's still untreated, the disease moves into latent syphilis.
Latency simply means you have positive serology with no clinical signs. We divide it into early, so less than 2 years, and late, more than 2 years. Early latency is still considered sexually transmissible.
And late syphilis is thankfully rare in countries with good antibiotic access.
It is, but the consequences are severe, manifesting decades later.
What are those classic late complications?
They fall into 3 categories. First, cardiovascular syphilis, typically manifesting 10 to 30 years post-infection, leading to aortic involvement, aortic incompetence, and potentially aortic aneurysm. Second, benign tertiary syphilis, which is characterized by the gamma chronic localized granulomatous lesion that can affect any organ. The skin, bone, like the classic saber tibia or skull lesions, the liver, testes, or brain and spinal cord.
And third, the classic forms of neurosyphilis.
Right. These include meningovascular disease, but also the horrifying historical presentations like tibialis dorsalis, which is a degeneration of the dorsal columns of the spinal cord, leading to gait ataxia and sensory loss.
And general paralysis of the insane.
Yes.
We also can't forget congenital syphilis.
This is prevented by routine antenatal screening, but failure to screen leads to stillbirth, neonatal death, or severe disseminated infection. The classic markers which form the stigmata anchor of late congenital syphilis are defects in bone and teeth.
So Hutchinson's incisors, mulberry molars.
Saddle nose deformity, saber tibia, and eighth nerve deafness.
Let's discuss the critical diagnostic process here. How do we monitor a disease that can mimic so many others?
Investigation relies entirely on serology. We divide the tests into treponemal and non-treponemal. The treponemal tests, like an EIA for IgG and IgM, are used for routine screening, and they usually remain positive for life, indicating exposure.
So if that's positive, you need to know if the infection is active or if it's been successfully treated?
Exactly. And that's where the non-treponemal tests come in.
The VDRL or RPR?
Right. They measure antibodies that reflect disease activity. They're quantified as titers, like 1.32, and they should decline fourfold after treatment. We track this titer to prove treatment success.
And you have to be aware of the biological false positive, RPR or VDRL.
You do. It can occur transiently in conditions like pregnancy or infectious mono or chronically in autoimmune diseases, and it requires further clarification with specific treponemal tests.
Finally, management. Penicillin is still the reliable drug of choice.
Yes. Penicillin G remains the gold standard. A single dose of intramuscular benzathine penicillin treats early syphilis. Late syphilis requires 3 weekly doses. The treatment is incredibly effective, but you must be prepared for the Jarisch-Herxheimer reaction.
Describe that reaction for us.
It's an acute febrile reaction, fever, headache, myalgia, that occurs within 24 hours of treatment. It's especially common in early syphilis. It's not an allergic reaction, it's a massive systemic inflammatory response caused by the sudden release of bacterial endotoxins as the spirochetes die.
So it's usually self-limiting.
Usually, but it can cause potentially catastrophic worsening of neurological or ophthalmic symptoms in high-risk patients. This requires prior administration of steroids, like prednisolone, to blunt that systemic response.
Okay, moving on to our other major bacterial challenge, gonorrhea.
Yeah.
You called it the antibiotic Houdini, and that adaptability is what makes it such a global health threat.
It really is. N-gonorrhea is a gram-negative diplococcus that has an alarming capacity to rapidly acquire and develop antimicrobial resistance, or AMR. This has led to multi-drug resistant gonorrhea, MDR-GC.
Which is a public health crisis. We're running out of reliable treatment options.
We are. Clinically, the incubation is short, 2 to 10 days. The male presentation is that classic profuse purulent discharge, But what about women?
It's mostly asymptomatic, right?
Women often carry the infection asymptomatically up to 80% of the time, with infection primarily affecting the urethra, cervix, and glandular tissues. When it is symptomatic, it presents with discharge, dysuria, or dangerously, it ascends into PID.
And the extragenital sites are key here, especially in MSM populations.
Absolutely. Pharyngeal infection acquired through receptive or genital sex is usually symptomless, but it acts as a major reservoir for the disease. And rectal infection is also often asymptomatic in MSM.
This silent carriage facilitates unchecked transmission and complicates the management of AMR.
It does.
What are the severe complications beyond PID?
The main ones are ophthalmia neonatorum, which is a severe eye infection in infants born to infected mothers that can cause blindness, and the rare but serious disseminated gonococcal infection, or DGI.
And DGI is when the organism spreads via the bloodstream.
Right. It typically presents as tenosynovitis, so inflammation of tendons, migratory arthritis, these characteristic pustular or hemorrhagic skin lesions, and fever.
Investigation relies primarily on night, but again, culture is essential for surveillance. Given the resistance crisis, what is the current treatment standard?
Current guidelines in high prevalence areas like the UK necessitate a very aggressive approach due to resistance. The recommendation is a single high dose of 1 gram of intramuscular ceftriaxone.
The no more oral antibiotics for first-line treatment.
No, not due to the resistance concerns.
Yeah.
And critically, we use sensitivity testing, either culture-based or increasingly net-based resistance detection, to confirm susceptibility, ensuring we aren't creating the next untreatable superbug.
Okay, chlamydia, the silent epidemic. It presents milder than gonorrhea, has a longer incubation, but the consequences of its silent spread are massive.
Chlamydia is caused by an obligate intracellular bacteria. Its asymptomatic nature infecting over 80% of women and over 50% of men silently is its danger. It leads to chronic inflammation and scarring in the upper reproductive tract,
which results in silent tubal damage, infertility, and ectopic pregnancy.
Yes. And other specific complications include epididymoorchitis in men, particularly those under 35. Both sexes can experience sexually acquired reactive arthritis, SARA, which is an autoimmune response.
And women can develop perihepatitis, Fitzhugh-Curtis syndrome.
Right, presenting as right upper quadrant pain due to inflammation around the liver capsule.
Now let's discuss the critical shift in empirical treatment. This is a major anchor for our medical student audience. The long-standing standard of single-dose azithromycin for uncomplicated chlamydia is out.
Correct. The new key takeaway anchor is that the preferred treatment for uncomplicated chlamydia has changed to doxycycline 100 milligrams twice daily for 7 days.
This is a profound change in practice, and is driven entirely by a different organism, Mycoplasma genitalium.
That's the therapeutic dilemma. M. genitalium is a common cause of non-gonococcal urethritis, NGU, and it's increasingly implicated in PID. The historical use of single-dose azithromycin for chlamydia was incredibly effective against chlamydia itself.
But it was also used empirically to target MGen.
Exactly. And unfortunately, M. genitalium has developed extremely high rates of macrolide resistance, up to 40% in some regions. So azithromycin was inadvertently driving resistance in M. genitalium.
So now we use doxycycline.
Using doxycycline for 7 days is effective against chlamydia, and it provides better empirical coverage for NGU while mitigating the resistance risk for M. genitalium. It's a classic example of public health strategy changing clinical practice.
And we should briefly mention LGV, lymphogranuloma venereum.
Yes, LGV is caused by specific invasive C. trachomatis subtypes, L13. While historically tropical, it's now a key cause of severe proctitis in MSM in the UK. Unlike the mild NGU chlamydia, LGV causes destructive, painful, sometimes hemorrhagic inflammation of the rectum and severe regional lymphadenopathy, or buboes.
All right, let's shift our focus to the viral threats, particularly those that establish latency or have that oncogenic potential.
Let's start with genital herpes simplex, HSV. It's defined by its ability to establish latency in the sensory nerve ganglia, which leads to our anchor, the recurrent visitor. The virus remains dormant in the nerve root, reactivating intermittently.
And that causes symptoms or, more often, asymptomatic viral shedding.
And that asymptomatic shedding is the silent transmission mechanism. It is the primary route of transmission. Most people who acquire HSV get it from a partner who is unaware they are infectious.
And there's been a major epidemiological shift.
There has. HSV-1, which traditionally causes cold sores, now accounts for over 50% of new anogenital infections in young people in the UK, likely due to changing patterns of sexual contact.
Clinically, What defines the primary episode?
The primary episode is the most severe and longest lasting. It starts with clusters of small, painful vesicles that rapidly rupture, forming multiple, shallow, extremely tender ulcers. The key visual diagnostic is that lesions are often at different stages of healing simultaneously.
And you get systemic illness, fever, headache, myalgia.
Yes, that's common, along with severe bilateral inguinal lymphadenopathy.
How do recurrences differ?
Recurrences are much milder, shorter, and usually localized, lasting 5 to 10 days. And they are significantly more frequent with HSV2 infection than with HSV1.
And the patient often reports prodromal symptoms. This is a high-yield point.
It is a sensation of irritation, burning, tingling, or even neuralgic pain in the affected area hours or days before the visible lesions appear.
Diagnosis is swift and specific now, with NET.
We diagnose by taking a swab from the base of a fresh vesicle or ulcer and performing NET for HSV DNA. Serology is sometimes used, but NET from the lesion is the gold standard.
And management strategy depends entirely on whether it's a first episode or a recurrence.
For the first episode, oral antivirals like acyclovir or valacyclovir are given for 5 to 10 days and must be started within 5 days of onset to significantly shorten the duration and severity.
And for recurrent episodes?
We use patient-initiated high-dose episodic treatment. For instance, acyclovir 800 milligram 3 times daily for just 2 days. The patient must start this regimen within 24 hours of the prodrome or lesion appearance for it to be effective.
And what if the recurrences are debilitating?
If the recurrences are severe or frequent, so 6 or more per year, we offer suppressive therapy daily, low-dose oral acyclovir 400 milligrams twice daily for a minimum of 1 year. This aims to reduce the frequency and severity.
Okay, now human papillomavirus, HPV, and anogenital warts.
HPV is arguably the most significant viral STI from an oncogenic perspective. It's a massive group of viruses with low-risk genotypes 6 and 11, which cause benign warts.
And high-risk genotypes 16 and 18, which are associated with over 70% of cervical, vulval, penile, and anal cancers.
The warts themselves present quite variably. They can be single or multiple, classic exophytic or outward-growing warts, papular bumps, or flat lesions.
And any wart that looks atypical or fails to respond to treatment requires an urgent biopsy.
Exactly, because of the association with underlying intraepithelial neoplasia CIN, VIN, PIN, or AN.
The public health triumph here is vaccination.
This is our anchor, the cancer shield. Vaccination, typically given to children aged 11-13, is hugely successful. The current non-covalent vaccine is critical because it protects against the 2 benign wart types and the 7 highest-risk oncogenic types.
And we're already seeing dramatic reductions in high-grade cervical lesions in vaccinated cohorts.
We are.
How do we manage the warts once they're established?
Management depends on size, location, and patient preference. We start with topical, self-administered treatments like podophyllotoxin, which is cytotoxic, or imiquimod and ketephin, which are immune modulators.
And if those fail?
We move to ablative therapies like cryotherapy, which is freezing, hyfurcation, electrical burning, or surgical removal. A key clinical detail. Cryotherapy is one of the few management options for genital warts considered safe for use during pregnancy.
A quick note on molluscum contagiosum.
Molluscum is caused by a pox virus. Clinically, it's easily recognizable. Flesh-colored, discrete, hemispherical papules with a small central depression known as umbilication.
And in adults, transmission is usually sexual.
It is. The good news is that they are generally self-limiting, resolving spontaneously over months, so treatment like cryotherapy is largely cosmetic.
Finally, let's wrap up with viral hepatitis. How do these common viruses relate to sexual transmission?
Hepatitis A virus, HAV, outbreaks are frequently reported in MSM populations because of oral-anal contact. Vaccination is available and highly recommended for this group.
And hepatitis B?
Hepatitis B virus, HBV, is highly transmissible through all forms of penetrative sex. It's significantly more concentrated in blood and bodily fluids than HIV. It's also a higher risk in high partner change groups, and vaccination is available and routine in many countries.
And hepatitis C, HCV?
HCV is traditionally less transmissible sexually than HIV or HBV. However, the risk is significantly elevated when sex involves mucosal trauma, like rough anal sex, and the risk explodes in MSM who are co-infected with HIV.
And there's no vaccine for HCV?
No, so consistent condom use is advised until the patient completes treatment and achieves viral clearance.
So to synthesize this immense amount of material, It seems you now have this systematic framework required to approach SPI diagnosis, moving from history all the way to pathogen.
Right. Your foundation rests on clinical assessment, a thorough, non-judgmental history that utilizes the gentle guide and dictates testing based on all anatomical sites at risk, regardless of binary gender.
When thinking about the pathogens, you have to remember the crucial anchors. Syphilis, the great pretender, with its painless chancre and systemic rash on palms and soles.
Gonorrhea, the antibiotic Houdini, demanding immediate IM ceftriaxone and sensitivity monitoring. The pH detective for differentiating vaginal discharge.
And that critical therapeutic shift in NGU and chlamydia treatment toward doxycycline, driven by rising M. genitalium macrolide resistance.
And on a larger scale, public health relies on the 3 layers of prevention and the proactive finding of asymptomatic disease via high-sensitivity, innate, and efficient self-sampling programs.
Okay, so what does this all mean for your clinical career? You have anchored the foundational map of STIs. The source emphasizes that while sophisticated innate testing is scientifically vital, the ability to rapidly make a clinical diagnosis based on a syndrome.
The pain versus painless distinction for ulcers, the quality of the discharge.
Right. That remains a critical life-saving skill, especially when laboratory results are not immediately accessible.
It does.
This leaves us with a truly provocative thought that sits at the center of modern sexual health. Considering the global rise in syphilis, the catastrophic AMR risk posed by N-gonorrhoeae, and the continued reliance on treating syndromes in many settings, how will the global healthcare system balance the immediate, crucial need for empirical syndromic treatment with the long-term existential imperative of preserving the efficacy of our remaining antibiotics?
I mean, the syndromic approach is a powerful tool for public health, but it fundamentally clashes with the fight against antimicrobial resistance.
So what will be the ultimate solution to this conflict?
Yeah.
Faster NAT-based resistance detection or entirely new non-antibiotic treatments? That's something to mull over as you begin your clinical journey.
Thank you for joining us for this deep dive into STIs.
Go forth and study well. We'll see you next time.